been okay. I'm actually, I think it's just been ups and downs inside of my soul. And there are some weeks I feel so much more like a poser than others. Do you know what poser means? Does that make sense to you? I swear there are times when I think that I am all that, John. I come up with something and and then there are some weeks that you just go, crud, am I just it I think there's ups and downs in life, and especially when I had a bad one yesterday, an exam where a lady came from an island, um, didn't have access to her car, biked to the ferry, took the hour ferry ride over. I'm about I'll bet I'm 4 or 5 miles from the ferry terminal to where my clinic is. She bikes. Now, granted, it's one of those battery powered ones, and so I'll give them some credit for maybe I think they've got to do some work in order to keep the batteries up. And she arrived at the clinic, and she was motivated because her insurance did not approve MRIs. The X-rays came back without any findings, and she's 50 years old, by the way, and just snowboarded 2 weeks ago. So, and it's supposed to be her knee. That's the problem. And after using it, it swells, which made you say, "What were you doing or thinking coming here on the bike?" But but I did the scan, John, and I do a I do a scan that I'm learning, and when somebody, what I find are large erosions in areas like lateral to the lateral to the trochlea, and before you get to the lateral condyle, and there's large erosions, and in the erosion is a cloudy whiteness, and I turn long axis on it, and it's this big, long, cloudy whiteness. And when I'm looking in the back for like Baker's cyst and what I can think I can find, and this is again, you're getting a little insecurity in my poserness right now, because I look in the back and the condyles where I normally see the articular cartilage, and I go on both sides. And I act in my own mind like I think I can see the cruciate region, but I'm not refined enough to know what I'm looking at. So I hope that God makes this huge black mass if there's a problem that has like complex fluid in there. Um, but I'm looking at this, and as I'm scanning on what my mind says is a sagittal scan in long axis, what normally I see as round has big, like, erosion pockets, and those are filled with some stuff. And I don't even know what some stuff would be. And so obviously I try to throw on Doppler to see if there's something at any of these pockets. And I don't know. I take it up to where it's completely filled with shiny stuff or spark, colorful stuff, and I bring it back down, and I have a vascular flow in one, so I know I'm seeing that, and I don't see anything in these little pockets, and and it basically comes down to where I discuss with the patient that I saw something that I think justifies her symptoms, and and then I send the doctor a note that basically says, you've got to put in a stat request for some tomographic imaging that you can actually slice through this stuff and see what it is. And I think I found something that justifies it, and this is what I think I found. But but I want to be a champion for this over here. And when I talk like, and so I think there's this soft echo mass that may be over this. I don't think I do a good job of representing this. So there's part of me that tells you that I think I'm pretty good if I can see a periosteal cortex and a little bit of fluid. But when I see areas where my mind says there's nothing that should make that bone be gone, and there's clefts, and even all this I'm sharing with such intimidation because of what's in your brain that I don't even want to show you the study, because I'm fearful that you're going to say, you know, I had some faith in that guy over there in America. So that's my truth of it, is I wish I could have the strength of confidence that what I'm seeing is something aberrant. And in the absence of that, I have to blow a whistle and look like I'm going to call foul when it might not have been foul. It might come back and show nothing other than, and this is where I have an absolute ignorant room in my head. I don't know if I've ever seen multiple areas where what I would normally expect to be the contour of bone goes away. I can literally see the echoes at the bottom of that, and what's filling it in is this cloudy, cottony stuff.
Yeah. Well,
So
it's better than a Netflix. I want to see it.
well, I will tell you what I will do, because I can't possibly stomach my mentor even having inflection in his eyes that I'm a loser. I will send you I'll send you access to my report, but you've got to know how bad I feel about it not being representative of the strength I want to one day have, so I can tell these guys, hey, it's this. I don't have that.
You don't, and you'll always get that. No matter how good your kit is, there will be days when you stick the probe on and you just go, I'm not sure why that's wrong. The term I used to use, in perhaps not in a report, but it offends me.
It offends you.
Yeah. No, when I see something that I know is wrong, but I can't verbalize it. I sometimes say, and it offends me. And that's how I tell it to my students. I say, I'm looking at this thing. I know I shouldn't be seeing that. But I can't quite figure out what on earth that means in anatomical terms. But I know from my experience of looking at it that it just shouldn't look like that. And that's
how do I put that into words? How do I say to the doc? I just say, hey, you've got to elevate this to a more.
That in a sense is what you say. You're looking at it. The picture. I often say things like appearances are ambiguous. What I'm not seeing is a normal articular region within the articular zone of the posterior medial condyle. What I'm not seeing a normal outline of the bone. I am seeing some material. There are some defects, and I am seeing some material in there. This image quality is poor, and I'm having some issues, and there were some issues resolving it. But I'm concerned that appearances are abnormal. But I'm not getting sufficient resolution or whatever to make out why, or I just can't. Appearances are just ambiguous and therefore non-specific. However, appearances are abnormal, or I cannot see normal anatomy, and I would suggest further imaging.
When you say that the picture offends you, I totally get it, but I don't have that wealth of data that my level of offensiveness comes up. And what I rapidly say is, I'm offended that I'm holding myself up as a specialist that makes me go, and I have nothing in my brain that I can say this is what it is. And it's just one of those things that, again, I've got to stop flagellating. I've got to start beating myself up, and I've got to say, here's the other thing. When I find that stuff, and the patient's with me, and I can't help but share the amazement of this glass bottom boat that I'm using on seeing their joints. And when they're engaging, particularly when they're engaging with any level of intent to learn, and I go over something, I can't help but the conversation doesn't have words to it. As I scan over this area and I'm looking at these things, and then the patient says, that's exactly where I hurt, right there. And then I'd like to ask you, what do you say to them?
Well, it's tricky. Sometimes you can't give an answer. If you're scanning something that is very abnormal, and it's very abnormal, and it's not a discussion that you can have with the patient at the time, that's tricky, and that's one of the downsides of having the patient watching you as you work rather than you picking your moments. But I do that with shoulders all the time. The patient is facing the screen when I scan the shoulder, typically in a physio environment, and what you generally have to do is be ahead of the patient. So you have to be thinking, I know that's something I don't want to discuss with the patient, and therefore I can look at it more surreptitiously, or just scan over it, take a clip, and go back and look at it in more detail. But you can also be extraordinarily honest with the patient and just go scan through and say, it looks different from the other side, and I'm not sure. And unfortunately, ultrasound can't answer that. The way the ultrasound picture is built up, and my limited expertise, and I'll be quite frank with the patient. I say I just cannot figure out what that area is. I think it's clinically significant, and so we need to get further imaging to get the answer to. And you just go there with that. In that scenario where you've built up that rapport and you're discussing the results as you go along, you need to put them in that position, and say, but it doesn't help if you're still making up your mind what it is you might be looking at. That's a tricky situation. There isn't a perfect answer to that. You just have to kind of go with it and try not to commit one way or the other, because that's hard to claw back from. So
they can tell that your CPU is going to a much deeper form of pulling on the bandwidth when all of a sudden the small talk stops and you go for a while, and you can tell my face. I have a hard time being UK stoic, and anyway, it was one of those things. Yeah. There's just some days that seem to pile on the element of you really don't know much.
That stuff doesn't go away. There might be the balance might change from list to list, but you get every day you'll have times, if you're on a busy list, you'll have times, but that's just true of the form. Ultrasound is an imperfect imaging form. It's with its strengths and its weaknesses, and the people driving it are imperfect as well, and their knowledge and ability, and that's the same for you as it is for me. It's there's and that envelope is different, but you are still there, and if you're not there, then you're in the wrong job.
Yeah, that's right.
You're too far below your weight. If you just turn up to work and everything is straightforward and you get it right.
I had another patient who came in too. She was a ballet dancer, just turned 15, knee issues, and pediatrics, or at least in that phase of life, where I don't know, and this is again my ignorance, I don't know where the epiphyseal plate is, and there's so many points at that age as you go over periosteal, whatever's. Fortunately, I think hers was just an MCL. Everything else seemed to be decent. But anyway, thank you for asking how my week was. Now let's go to your list and let's see what you have.
I was going to talk more about yours this week because I really haven't seen very much. I was looking back through it and I've not got an exciting list at all. Sadly, I'm thinking from things that I've seen since you were. I think I'll just go through what we have. And there have been bits and pieces, but not the usual run of things. I've had a lot of stuff's coming through for injection, and so we don't get, and so that just intrinsically makes the list slightly less exciting.
Because will someone have already screened it?
Well, no, it's often they're relatively straightforward cases, and they're just for they come in, and I might do some ganglions or frozen shoulder. Just needs you scan it, but it's just a cuff tear, or it's a frozen shoulder, and it's a frozen shoulder, so you do an injection for a frozen shoulder. So that's one of the variations. Let's have a look. Am I sharing now?
Yes, I can see it. It's not huge, but I can see it. There we go.
So I think this is just a loop of.
Oh, that's beautiful, John, because I have a question for you on that issue. Yeah. The bottom of the infraspinatus tendon. I've had a couple occasions this week where the humeral head showed little debris-like stuff, and it's almost as though the lower part, like the anterior fibers of the infraspinatus enthesis, or whatever I'm trying to say, is either striking or affecting the labrum or the glenoid. Do you see much of that? Do you see?
Not very often, but when you see it, it can be really significant. I remember specifically this classical guitarist comes in, and he has an absolutely normal shoulder scan. This list I was doing with a quite senior colleague, and we're both interested because this guy, classical guitar player, played in this, which turned at this sort of position. Knows they can play up here or they can play here, and he turns up and he scan him, and his shoulder rotator cuff looked like it came out the box. It just looks absolutely perfect, and you think, why is he getting that pain? And I don't know. When you get patients and they don't have pain in this sort of arc, but they definitely get pain at the ends of the range, and you think, this maybe in an older person, it sort of looks, you'd be thinking slightly towards an osteoarthritis if it didn't have a frozen shoulder pad. Anyway, we scanned the back of his thing, and we said, what's the painful position? And he was slightly hypermobile. And so we scanned the back in full external rotation, and the labrum was jamming up against the infraspinatus, the greater tuberosity at the back. Yeah. And he was literally just bashing against it. And he'd go, "That's my pain." And we'd just take him and go, and we're scanning it, and we're going, "Yes." So you need to come off end of range, because he was literally hanging, because he was hypermobile. And it gave him a lovely position for playing, and that was it. So you do see it. You don't see it often, or at least I don't see it clinically often. But you have to go there to find it. You have to look at, because often we go into internal rotation to look at the back of the joint. And I know John, your John Jacobson, scans them in neutral when he does the back of the joint. He doesn't bother putting them arm round here. I do put the arm round here, but I do it because I like it. It gives you access to different parts of the tendon. when I'm looking at because I follow infraspinatus in short axis, the muscle onto the insertion and back. And I do that in the sort of karate punch position, which is my normal position for scanning supraspinatus. Am I losing you?
No, I'm with you, but you're saying you do the short axis scan of the infraspinatus with the arm in the karate punch position, or is it across the body when you're doing it?
Well, no, I do. I scan infraspinatus in the same position I scan supraspinatus. Show
me that again with your left arm.
Sit up on a slightly higher chair. So I sit in my kid's chair. Yeah. So I normally have my patient sat in a low-backed chair with no arms, and I take the arm back into this position on the back of the chair. And
that's what you scan infraspinatus.
This is what I scan supraspinatus in.
Yes, I'm with you. Yes.
So they sit on a chair. If they're elderly and got sore shoulder, they just lean back on it, and the arm just hangs off the back.
Yes.
With the palm forward. And then they just rest their hand on the back of the chair with their palm facing in the same direction as their face. Yeah?
Yes.
And that's a relaxed position. And 99.9% of people can get into that position one way or the other. Certainly a very high percentage. And I scan supraspinatus in this position and infraspinatus. And it's just a matter of where the greater tuberosity is. You scan through.
Yes.
Yeah. And in both, and scan and by changing the probe angle, you can get a good view of both of them in long and short axis. And then, if I'm having any trouble seeing it, I then take the arm round a little bit further into what's more a classical position for scanning it. And I do the same, but I do this for supraspinatus if in those patients where the acromion covers the supraspinatus. Very occasionally you get patients where in this position you can't see supraspinatus very well. We had one today actually on my fellows list. But for infraspinatus, that often helps if you turn it round and then you scan it quite nicely. But you sometimes the back corner of the acromion covers the tendons. You can't follow the infraspinatus tendon all the way back through, and that's what this position is particularly good for, because it brings the infraspinatus out from underneath the acromion in those patients where it's difficult. So you see it quite nicely there, and you get to see the joint with a little bit of a stretch, material on it. That's good. But in that position also, you can test the end of range. If they have this in their pain, if they're struggling with external rotation, then I tend to look at that. And I looked at it specifically as well in cases where I suspect frozen shoulder, but it's still ambiguous because
you look at the posterior joint line with frozen shoulder. What are you looking for there?
I'm looking dynamically.
Okay. Okay.
See what happens when it stops. You take it back and it stops, and there's no bony cause all the way down as far inferiorly as you can go. So you're moving it, you're looking at it, and you're not seeing. So if you look back at this, sorry, I should have stopped sharing, shouldn't I? So you could have seen that in big picture. But you see here, this is OA of the shoulder. But you can imagine it in normal shoulder. If you see the glenoid abutting against the greater tuberosity at the end of range, whatever their range is, then you can be fairly sure that it's not the capsule that's holding that's limited.
Yes.
So, but you're looking in some patients, see whether there is some underlying problem there. But it's also the clinical significance. You do get frozen shoulder in patients who have osteoarthritis of the shoulder. So it's not common, but sometimes in that early onset OA, but diabetic in their sort of late 50s, early 60s, you might want to differentiate between the two, and that's one of the things you do. What's limiting external rotation? Is it more the OA or is it the the superimposed frozen shoulder.
I have two questions for you. One was still referencing the postures that you were in, but the question is this. You seem to say, I will scan the supraspinatus and the infraspinatus unless I'm not able to see as much of it as I want. That as much of it as I want, I'd like to have you clarify for me. Does that mean that you're taking the collagen into the muscle so that you've actually gone into the myotendinous junction? Must you see a darker color for you to feel as though you've scanned it adequately? What is it that's the criteria for you to say, oh, I'm going to go back to the more classic position? What is it that
it's not that you should, it's normally an anatomy. Normally, for whatever reason, their anatomy, you cannot see enough of the tendon to see normal.
So your eyes are not seeing, let's say, the interval where you're seeing the long head of the biceps and the infraspinatus over the top of it, and you're saying I need to see more of that?
Yeah, it's not normally, muscular tendinous junction is very variable. I'm just get up a normal shoulder, a normal super. Yeah. So we go to a normal shoulder scan. Hopefully this will quite a lot of this. So yeah, so you're looking at, you see a supraspinatus like this, where you've got the remnants of the greater tuberosity. You've got the acromion. Sometimes those two points are much closer together.
Okay, I'm with you.
And in your just karate punch position, the extension, no abduction, no internal rotation position, which is my favorite position for initially assessing supraspinatus, because the anatomy is very, very stable as to where everything is. But you're talking this. Yeah, just by karate punch, I mean just there.
Okay, all right.
So anatomical position, just back to there.
All right.
And I do that just by letting the patient sit against it on a chair and just let the arm fall back, but keep the palm forwards, but no internal rotation, not on the pocket.
Yes.
Because the larger people will just do this, and that makes it very. As soon as you get in the abduction, it's very difficult in some patients to get a decent view, and a lot, and it's often in the bigger patients, it's very easy to let them accidentally slip into abduction, and then you just don't get a good picture of the cuff, and you don't get good orientation of the fibers. So I'm often, and the typical thing for my students to do, because they know when I need to be, I'm reasonably persistent in getting some external some extension, and they'll do this, and the patients will get really sore. And then I come along and scan, and I just say, no, don't bother at all. Just lean back against the chair, let the arm hang down. And that will do for me. For most patients,
they're trying to be intentful, and you're trying to just let the arm hang.
Let the arm, you get more extension and a better position in a painful shoulder just by getting to lean back and let gravity take its place.
That makes sense.
We'll often let you, almost like when you're teaching them their pendular swings, trying to get them to do just drop your arm down. Just drop your arm down. I will make do with whatever picture I get of supraspinatus, because I know as soon as you force against that really unpleasant pain, what you get is this, and you just don't get a good view. So you're better off, relax, go back. You scan it there for a few seconds, they'll take it a bit further back. You then just twist the arm like like they're emptying a bottle. So no bending the elbow, just literally turn it back like that. And you get a few more degrees. And each little bit gives you a little bit, just draws that thing out a little bit. And you just get a slightly bigger view here.
Take me back now again to your posterior joint picture that you were going to show me on the first part, and I wanted to get your take on. You said this is OA. When you're taking a look at that, is it the the large calcifications that you're seeing in the humeral at that anthesis, or are you looking at the dimension of articular cartilage as they go into external rotation? Talk to me about that.
Well, it's only a very short clip, but there's probably plenty more in the library. You've got the glenoid there. You've got, on this one, you've just got very limited articular margin. You're right up to the stop after a very short period of time. This arm's only coming out to where a stiff frozen shoulder would be. And you've lost the contour of the humeral head or thing. And this is just not the right shape in this case.
That's the OA.
Yes, that's OA. That's just osteoarthritis.
Do you provide categories to that when you do your dictations? This is severe OA. This is.
Oh, yeah. I will. I will say if it's severe or mild. If I'm only seeing a little bit of change, I'll say see mild OA. You know, just that a little bit of lipping at the edges of the thing, or I'd say the big old osteophyte at the bottom, posterior inferiorly, or in keeping with quite severe OA, or when it just looks rubbish, you just say that's severe OA. But or some moderate things. But the X-ray and the ultrasound are not going to be directly correlating. And the MR, because on the ultrasound you get a very good view of the osteophytes, probably easier to interpret, I think, than MR in that sense. But you don't see wear of the articular cartilage. You certainly not at the glenoid. You don't see the changes of the glenoid. So you're missing out a big chunk of the story, but you get lovely appreciation of the functional changes. You know, it's not on the MR. You've got no idea whether the osteophytes posteriorly are clinically significant or not. On ultrasound, you've got it, and they're going whenever you get to the range. You kind of go, you know, actually, we put it beautifully in context there. Let's see, and so I think this is the same shoulder. I don't know whether you don't get to see anything. This is with the we're in external rotation. So in internal rotation, I inject them in this position. So we're not. I thought we might be seeing a bit more information on it, but no, you're just seeing the.
Is this real time, John? I mean, I guess it have to be. This is the way that this is the amount of time it took you to get your needle down and deliver the injectate and then come out.
Yeah, that's from when I put the needle in. I cut the clip from when the needle goes in to delivery. So there's the needle coming down. I mistimed my angle, so I've changed it slightly, gone in straight, and go there. So I try and make that initial judgment as to whether I've got the angle right as quickly as I can. So there, I'm too short, too shallow, so I go back. So just that bit at the start, you'll see, you just go, the needle comes in, you go there, and you just, in your mind's eye, whoops, I shake that back. In your mind's eye, you draw a line along there and you go, is that in the joint? No. So you draw the needle back and go a little bit steeper. So you draw the needle back and then go a little bit steeper.
Yep.
And then you go, yep, that'll do it. And then you go, and that just, and some of that is just practice.
Like 98% of that, John.
Yeah, but some of it is literally just practice. I sit there, you know, when I have a quiet moment, I'll put the probe onto a piece of paper. I'll draw around the probe. I'll load up put a needle on a syringe, and I'll put the needle and the syringe onto the piece of paper next to the probe, and I'll draw a line down from the middle of the probe with the centimeter marks on it.
Oh, you've totally lost me, man. Back up again, because I don't. You're on a piece of paper. I'm assuming.
Let me show you. Okay. More easily done. If I stop sharing, if I share screen, there we go. Whiteboard. So I've got a blank piece of paper. I lay my probe down on the piece of paper, yeah, like that.
Yes.
Yeah. I draw around it with a pencil, yeah.
Yes.
I then draw a line from the middle of the probe that direction, and I put my centimeter scale on it. Yeah.
Yes.
Yeah. I then get my needle, my standard 2-inch needle, which is 5 centimeters, which is the length of that line, with a syringe on it. Yeah.
Yes.
And I put that here. So I normal entry point and it's down to 4 centimeters. And I look, just get used to the look, because when you stick the needle in, you can't see the needle.
Yes.
But you can see the syringe.
Yes.
You look at the angle there.
Yes.
That is made between the syringe and the distance there, which is less than a centimeter.
Yes.
And you just get used to what the syringe looks. You see, what everyone's thinking about the angle of the needle. No, because you don't see that. You're holding the probe, and you know what angle. You get used to what angle that is. That it will take it down to 4 centimeters. And so when I stick these in, this gentleman's got quite a slim shoulder, so it isn't there. This is the glenoid, but normally this point in most sort of larger 50-year-olds, this point's normally at 4 centimeters. And so I practice that angle. So in actual fact, I'm generally quicker when I'm doing someone who's slightly bigger because they've got a 4 centimeter thing, and I know exactly what angle to put the probe in, the syringe in next to the probe, and I can just drop it in. And I know that if I've got my probe there and my syringe there at that angle, the tip of my needle will be on the 4 centimeter mark, plus or minus a millimeter. But there's no rocket science to it. I'm just used to what that looks like. And so I'm not, everyone gets very obsessed about imagining the thing in the patient and getting that. I'm not. I'm literally I just know that if I plonk it in any space and I get that plane absolutely right. So all I'm doing is I'm making sure that the syringe is in the plane of the probe, and I just practice like that. And it doesn't have to be in a patient. If you just get used to putting, so the probe could be anywhere, and I could put it down, so long as I look at the probe and I've got my head in line with the probe, because there's a little bit oblique, and so they go in a little bit oblique. If you look along the probe and you stick it in, it will be, if you get that angle right, when you've got a 5 centimeter, 2-inch needle, it will be at 4 centimeters in the plane of your picture. So all you have to do is you start off, you get the plane of the picture right. You make sure that if you accidentally move a little bit, you've got a little bit of play in there, just in case you make a mistake putting in. And then and I use very little jelly. When I do injections, I've cleaned all the jelly off, and there's only the amount of jelly I need on there. So if I fiddle around, I don't cover the whole area. So when I'm holding the probe, my fingers are in contact with the back of the probe in particular. So I'm well away from the target, from where the needle's going to go in. And the probe stays still. So I look at it, I get the picture right, so that it doesn't move around. I hold it, and then I pick up my thing, do my final clean of the skin just in front of the probe, pick up the needle, put it in at that angle, at the 4 centimeter angle. And I put it in, and then you look at you don't look at the screen while it's happening. You've got that, your hand's still, so the pictures shouldn't be moving. You push it in, you turn around, you go, needle's in the right plane, you take it to the target. You take it down. You put it in.
It's like you're practicing pitching so that you can hit the strike zone. Over here, you are just going through the motions of hand-eye coordination and the appearance of what the syringe looks like in relation to the probe.
Yeah, exactly that. And you're using your landmarks. And your landmarks, when you're putting in a needle, is not on the picture. Not when you're putting it in.
Yes.
Your landmark is the orientation to the probe of the syringe, and then you're there. and it sounds arse about face, but when you think about it, I don't understand why everyone doesn't practice like that, because it's like, you know, a butcher just going, you know, if there's something that's a little bit tricky that he has to do, but he's got to be able to do it right, you just go home and practice. You know, you cut up a bit of meat a couple of times when the pressure's not on.
Right.
When you're doing a deep hip injection like I was doing this morning, we're down at 6 or more centimeters, and it's deep. You know, then you want to be able to just go, that's going to get me close enough.
Wow.
You know?
Too much.
Yeah. But you know, you know, practice makes perfect. And,
6 centimeters because they were large. Were you doing an anterior capsular injection?
Yeah. So that would be, that's these things, they just require practice. But what you can practice on the patients. You do. That's why they call it clinical practice. But anything you can do outside of that is very helpful. This is a median nerve.
I'm going to need to have you take the drawing thing off, John.
Yeah, that would probably help, wouldn't it? I'm seeing some great pictures here.
So. There we go.
You know, let's have a look. Let's take that back to the start.
That's median nerve?
Yeah.
Now, is this something that you determined it needed it, or it was on your list to inject the median nerve, or how did that?
A bit of both. Sent to me because the patient wanted an injection for carpal tunnel. But I would, as part of my job, it's to make sure that that's appropriate.
Do you then do the measurement, comparing it to 10 or 12 or whatever at the inlet, or are you just looking at it in its long axis and determine whether or not it looks like my belt line?
I tend to the latter, I'm afraid. I'm not a great measurer of anything. I very rarely measure anything. I tend to use Mark 1 eyeball, and is it big? Because for me, is it bigger than it should be? Does it change? It's how much it changes, and that's very subjective. And I don't enjoy measuring median nerves. I don't find it very satisfying in terms of what the outcomes. And actually, my experience is that despite the stats, the measurements are not terribly reliable, terribly clinically relevant. You know, because everyone gets, particularly the absolute measurements. I think maybe the work done looking at the amount of change might be there, but then that becomes a much more complicated process. And I think, in my opinion, the visual, as you scan along the nerve and you see it change in shape, I think your subconscious is probably better at making that judgment than the measurements. Probably more sensitive.
Again, the concept of, does it offend you?
Yeah.
Does it? So talk me through this. You've done a delivery of the injectate superior to the nerve, and then you came back and you did it under the nerve. When do you know you're done?
When I run out of stuff to put in.
and then you just parse out the stuff, half on top and half on the bottom?
Well, what I'm trying to do is when the guys do their nerve blocks, what they're always talking about is getting it to go all the way around. And so that's all I've done, really, taken it from there with no real logic. That's, you know, but that's what I look to do. If I just try and get the fluid to go all the way around where I put it. I don't use high volumes. I use maybe 1 ml. It's probably as much as I'll do 1.5 mils, which I know is a lot less than my colleagues.
What is the change in the patient's complaints before and after a carpal tunnel injection like this?
Sometimes they get some benefit for a period of time. We haven't really followed up enough. I do them rarely because they take quite a long time to get to me in general. And so the ones that do get to me, they come in, I see yes or no, they've got changes that are in keeping with carpal tunnel syndrome if they haven't had nerve conduction. And then I look at their sensory changes and changes to their muscle mass and where they've got weakness. And so many of them turn up sort of having been sold the idea of an injection, but they've got non-changing, constant paresthesia. And even if it's relatively mild paresthesia, if they can't convince me that it goes away and comes back again, then I have a very low threshold to say, actually, there is a good, easy, safe surgical technique that will decompress this nerve. And so if you have changes on there that suggest there has been some damage, some loss of nerve there, so you're getting sort of what I call permanent paresthesia, or a particularly permanent sensory loss, then I, as far as I'm concerned, I wouldn't inject them.
You also clarified that they did not have nerve conduction studies. You said if they didn't have nerve conduction studies. If they came in and they had nerve conduction studies, would that be a criteria that you would inject in any event if they had nerve conduction?
If they have nerve conduction studies, from my opinion, depending on the nerve conduction studies and the result, then if it's unambiguous carpal tunnel syndrome, then I am less, then I would weigh less on what the ultrasound is, because I think a good nerve conduction, reliable nerve conduction study is the more sensitive test.
Okay.
And more sensitive, more specific. I would still have the same criteria. If they've got that and they've got some marked sort of non-variable, non-intermittent sensory change, then I would be discouraging them strongly from having a steroid injection, because I think the outcomes are going to be worse, because it's only going to put them off. They're going to take time after the symptoms all return, any improvement wears off, when they will continue, when the actual quality of the nerve will continue to deteriorate in a permanent way, which it does by and large. There probably is some recovery after decompression, but the surgeons report very little that you get taking away of the pain, but in terms of return of sensation, you get very little return of sensation post-surgery. If it wasn't a sort of acutely compressed, you probably, if you've got someone who's got a lot of changes there, but at a relatively recent onset, then you can imagine it coming back at some stage. But for the ones that have left it, as they typically do in a public health setting, where it might have taken them another 6 months to get back to us after their symptoms got worse again, then I think the damage to the nerve then is the increase in permanent damage means they just have a reduced sensation as their end result of your injection, essentially. So I'm not so I don't end up doing very many of these. I do far less than I used to, because my criteria is become much harsher in that sense. I think there's a relatively short window of patients that still have mild symptoms, not getting enough benefit from management. Mild intermittent symptoms they can have quite a lot of pain, but it's the sensory symptoms are intermittent, and it's too irritable to just get better with splints enough. That narrow thing probably benefits from an injection. And there's a potential that you're actually doing something relatively curative. If you can get the irritation down with the injection and then get them to do the behavior modification and splinting, they then have a possibility of getting a better outcome. But that is not the majority of patients I see in my practice that come through. And so I tend to be quite, this is you need to go and see someone else. And I will say that if they haven't had nerve conduction, I will say that based on the changes that we see in the nerve.
One more?
Yeah, I'm just extend. So ganglions are less interested. Did you see this? I think you probably saw this loose body last time. I'm just, I happen to be on the.
No, I didn't see this. I don't believe.
Loose body in the elbow.
This is from orient me. This is the posterior aspect down at the insertion of the tricep.
Yep. So let's go. Oops. Yeah. So there's your that you should recognize that.
Yes.
Short axis under the triceps. So the triceps a bit over here in this case.
Why does fat? Why is it white? Is it bouncing signals off? Why is it
the tendon here or this bit here?
That bit there, isn't that the fat pad that exists?
This is fat and fascia in what is a very arthritic joint.
Okay, I get you.
So as a mixture of fat and fascia, I suspect. This was not the great. This patient did not enjoy being scanned. So I didn't get a nice window, and I was trying to get a picture of this thing in motion.
Because it was locking, or it was snapping, or it was doing what?
Yeah, just you don't. I haven't got the plane of the snap, but what you'll see is it just physically disappear.
It disappears as the negative pressure draws it in, or it disappears as it gets squeezed out like a watermelon seed?
Yes, gets squeezed out like a watermelon seed. Did you see that?
Yes.
It just pops out like that.
Yeah, that's a good one.
Yeah. And in a perfect world, I'd be in the other plane so you could see it scoot across.
Yeah.
But I wasn't quick enough, and I couldn't get him to do the same thing twice. He was quite uncomfortable with that one. So you get what you get, and you don't get upset.
Did you intervene on that, or did you just send him somewhere to have it taken out?
Go have it taken out. You know, that's you're just wasting someone's time if you are. I think if you hold on to him, sometimes they can persuade me to do an injection, but not. They have to try very hard because I don't think that's large. This was a very. I felt almost guilty not sticking a needle in this one.
Because it was very ripe for aspirating or
Yep, that would have been.
You didn't do it?
No, I didn't do it.
And you didn't.
Symptoms didn't warrant it under the circumstances. This is about to get better, and he had felt some improvement. I just said, actually, these do get better on their own. There's a lot of calcium in there. I think it might be very painful. If it is, come back and I'll inject it. But your symptoms are not too bad. And I think it's so far out of the tendon that it did. But another day, let's say that's
beautiful. It's beautiful because it shows the varying posterior acoustic shadowing as it goes through that, and you can see the area where the summation has taken the ability to see any echoes through it. It's just beautiful. It's crystalline, and
it's distorted for me. That I'd be keen. You're getting a little bit of fluid in the bursa, but it's also changing the outline of the supraspinatus. And these often have the pain coming up. This is where they get mistaken for frozen shoulder.
Because when they come up, that approximates on the acromion, and they can't go any higher up.
Yeah.
Yeah.
Or they're painful when they do that. So yeah, no, that was an interesting one. We're just, things are getting better here on the COVID side, but I'm not desperate to put needles into patients if they don't need it at the moment, and that would have been done more for my.
You mean, John, you didn't want to have pictures of that stuff aspirated in this large thing on the counter, and then a picture of you smiling as the person then goes through full range of. Yeah. He was doing it already.
But yes, that's a great ego boost, sticking stuff in and pulling stuff out, but just not always necessary.
Yeah.
And so we don't. I tend to be quite conservative in the actual doing of those, just because they so many of them get better with just an injection. And but in that case, I would probably, if I was going to do anything, I probably would have put a needle in and tried to draw some of it out, because I think probably decompressing it might have been the right thing to do.
Especially if he was in lots and lots of pain. Well, John, as always, thank you for your time, and I will reach out again. Know always that you can bump it if you need to, but it's actually. Do you have a time change there ever, or is it coming up, or?
I'm not sure. I think it's it could be. It's usually sometime at the end of October. Let me see. If I go clock change 2021. Let's see what comes up. Daytime, so 28th of March.
So you're coming up next week or week after that, and then you're going to be back to where, when we talk, you are going to be. You're 8 o'clock there right now, correct? Or you're 9 o'clock now?
Yeah, 9 o'clock now,
yeah.
And it will be. I'll have to work it out.
That's okay. I think it will be back to where your 8 o'clock is my 12 o'clock, because right now your 8 o'clock was my 1 o'clock, which is why you'll get a thing on WhatsApp saying, "Hey, buddy, are we not going to meet?" And then all of a sudden it's, that's right, the time changed. Anyway, tell your family hello and take care of you, and maybe next time we'll see you looking a little less like that country music singer.
My plan is we just haven't had time, because normally lockdown normal is I give them the clippers on a 5 setting and just let them do what they want, and then Christine comes and tidies it up with a number 2 on the sides.
Yeah.
But they just it's been cold, and I normally do it out in the yard. So this weekend, if it's sunny, then you'll see me shorn. But I won't have been to the barber.
Have a good one, John. Take care.
Bye-bye.